Thank you very much for so eloquently setting the stage for us and giving us so much to think about this morning. We do have time for questions. I would ask that for those of us in the room, please remember to push your microphone button so that those on the webinar can hear your questions as well. So I open it up to questions.
Obrigado, Mr. Minister. Very fantastic presentation, and congratulations on the reform initiatives that you are undertaking. I'm Sarita Verma. I'm from the University of Toronto. We are working closely with your leading university, University of Sao Paulo, to help with the curricular reform. It seems that you're absolutely correct. The traditional approach is not necessarily going to prepare the graduates for primary care practice. And it's been noted by us as we go and work with the curriculum that there is a lot of resistance actually to bringing primary care, the focus being very much on the very specialized areas of cardiology, pulmonology, et cetera. How are you managing that dialogue with first the students who say, well, you know, we have 9 hours of lectures a day for 6 years, and with the faculty who seem to be not necessarily understanding that primary care is the direction they need to go in?
You are absolutely sure. I think that the most of the curricula in Brazil is quite traditional. We are going to make those changes. Let's say it starts with pediatrics department, with social and preventive medicine. I think the same thing sometimes happen here. But anyway, at this time, when the students know that probably primary health care will be a good work market for them in the future, probably they start pushing more. How can I be trained on this new idea? I'm talking about, you mentioned University of São Paulo, that probably is, I don't know if the federal of the state, but they are quite traditional institutions. But I think none of them are quite absolutely homogeneous, because you have in the school primary health care centers, people making movements in order to go to the peripheral family health teams, to train in family health teams. But I think this is a movement that I started setting a rural internship. That was the biggest one, it still is the biggest one in Brazil, in the most important medical school in Brazil, in 1978. So, but if this changed medical education, yes, there is some change. But if you take the medium student, not of the best school, not of the worst school, but of the medium of the medium, he still has this role model to practice in the hospital, to be cardiologist or to be radiologist or to be. I think that things move, but move much slowly than I wanted to. I think there's the same. I have been hearing Arthur talking about New Mexico for decades, and I think we agree in this idea.
Thank you very much. I'm Jan de Maas, the Secretary General of the Network Towards Unity for Health, and from Ghent University. We had the opportunity recently in Fortaleza to have an international conference on health professional education, and we all were inspired by the dynamism of the Brazilian people that attended, both the students and the professionals. And I think Brazil has been the first country that really achieved to scale up capacity in a way that responds to the needs of society. And so for me, one of the questions is, how can you make that professionals that are most of the time rather individualists, that are looking at their own situation, that want to take their own decisions, can be integrated in a broader societal project? And I think that that was the challenge that Brazil managed to overcome. And of course, it's still difficult, But you see there that the healthcare workers, they really want to commit themselves to achieving results in relation to the challenges and the needs of the population. And I think that's the essence when we train health professionals, is that we make that happen. So I would like to have your comments on that, because I think that's really an issue.
Yes, thank you, John. We saw each other many times in TÜV meetings for decades, and I think that the best of the intelligentsia in the world that's trying to move is networked in your institution. And I think that you are completely right, because what happens is, despite the fact that we have in the Constitution written, we have a strong movement. For instance, right now, one of ideas that I have, and I have been discussing this with the Minister of Education, the Minister of Health. If you are going to create 100 new medical schools, why are you going to them as conservative as the other ones use it? Because if you don't do a movement, and I think Henry Campos, my relative Henry Campos, that you know well, is doing the same. Because if you leave them to prepare to open a new medical school, what are they going to do is to take a Xerox of the curricula of the University of São Paulo. That was a Xerox from Hopkins. So the Xerox, and the Xerox is going to be faded in the future, because you don't have in Barbalho, in Ceará, where you stayed there for the meeting of the network. You are not going to have so many PhDs, so you cannot just make a Xerox of the traditional schools and replace them. And last week there was announced that I think 15 more medical schools in Brazil. We need to have more physicians, but we need to have them in a new model. We cannot have them in the traditional model, because maybe this is the big opportunity that we have right now. Because if I have to set a new school in a place where I just have community health workers and primary healthcare physicians, I have to rely on them in order to build a new model of medical school, not the traditional one based just on specialists. I think that we cannot lose this opportunity to make this expansion movement that we have in Brazil, to make something that's different, not just in the number of the graduates, but in the quality of the graduates, in order to make them more linked to the primary health care and to the idea that Brazil has, that health is a universal right and health is for everyone. It doesn't matter if you contributed for any insurance, that you are going to have a right to the health. Thank you very much for your question.
Good morning, and thank you for a great presentation. I have been in your beautiful city, Curitiba, and working with Heimar Marin. And so could you talk a little bit about how, I know you use the internet and technology for education, but I know you're also making great progress in how it is you connect clinicians and the data about their health with some of your more tertiary centers. And so could you just speak to that? Because I think that talking about the 21st century practice we need to move to, I know you're making progress there.
There was a doctoral thesis in Brazil that stated that the main reason for people not keeping their appointments in the rural communities, rural settings, was not for instance, salary. WHO worked as well in the resolution about that. But was isolation, was loneliness, was the idea that the physician goes to the city, the next facility will be 6 hours in a boat. So if a woman is delivering a baby, he decides to put her in the boat, probably it will be a catastrophe. Or he convinces the mayor of the city to hire an airplane to make the airlift from this place. The third one that he's going to convince the mayor to have an airplane, it's fired because the municipality cannot afford to do this. So because of this, we launched this idea of the e-health. We call it telehealth because it's not telemedicine. We think that we are against the idea just medicine is in this idea. And it has two components. The first component is the second opinion. So if you have any problem, you can connect to the next center and to have the opinion of the other professional. But it works as well as the way to train people in those cities. And we use this because Brazil has three big expansions of the health sector, of education. Right now, we prepare twice more professionals in the university education that we used to prepare before. And the internet connection is possible. We still have problems. In the right bank of the Amazon River, sometimes, for instance, all those Cubans that are there, all those professionals that are in Brazil right now, they receive a PDA device pregnant of our educational programs. But it needs to have a connection, broadband to internet to have the programs running. I think right now about 5% of those cities where I show, especially the ones in the left bank of the Amazon River, right now don't have internet access. So we still have problems. But most of the country, I've been discussing this with our colleagues that speak Portuguese in Africa, for instance. The situation in Brazil is completely different of the one that we have in Africa because broadband right now is available for, let's say, 95% of the cities in Brazil. The effort of the government was to bring the high broadband connection to the school. And in general, in the small cities, the school is the 1 block away from the clinical center. So if the internet goes to the school, because it has to go, because it was in the plan of the government, it must go to the health center as well. It's I think 3,500 units right now are connected through broadband to the internet, and the government, for instance, made an agreement with the British Medical Journal for a portal in evidence-based medicine. So, any practitioner in the network can have access to database that are available for everybody in the world. I don't know if I answered.
Liza Goblat, Chair of the Academic Consortium of Complementary and Integrative Healthcare. I believe that you mentioned that in some of the areas outside the major urban areas that the municipalities, the communities can decide who their community healthcare workers are going to be. And I wondered if you could describe the variety of community healthcare workers that you have and if any of them include some of the traditional approaches and traditional medicines.
In the Brazil, it was quite difficult for us because we took the decision 7 years ago to make a constitutional amendment. It's not easy to make a constitutional amendment because all the recruitation of professionals in Brazil must be advertised at national basis. And in this case, for instance, if you open a place in a very remote area, can somebody from São Paulo to be candidate to be the first one selected and sometimes does not go, etc. The only exception in the Brazilian Constitution where you admit the idea of the locally recruited public workers is for the profession of community health workers. Community health workers right now probably we have, they are politically quite strong because they go to the visits, they go to the residences, they can elect a representative. Because they enter any house in the, so if you imagine, probably the lobby in our National Congress of the community health workers is almost the same political power of the physicians, because they are quite strong people in terms of the capillarity that they have in the society. In general, for instance, in big cities, some of them are bachelors. But in small cities, some of the only thing that it's a national requirement is literacy. Literacy has to be capable to relate to the population. The try is to select people with the same cultural background, etc. And in general, each team has 6 community health workers. We do not accept the idea in Brazil. I've been working with WHO in this idea of I accept many countries can have, for instance, traditional healers, etc. In Brazil, all of them are professionalized. So we don't have community health workers there to work in voluntary basis. All of them are remunerated, are part of the system, and they relate to, in general, a small city of 30,000 inhabitants, they do have, let's say, 5 teams, 5 doctors in the 5 teams, 5 nurses, 5 auxiliary nurses, most of them with a dentist, and all of them with 6 community health workers. It can change, because if it's a large territorial extension, for instance, to make a home visit, you can spend, let's say, if it's in the city, you can go one house is wall to the other one. So you go see the vaccination here, over there. Sometimes you have to navigate from one household to the next one. You have to take a boat and go 3 hours. So some of those teams that are in very, very remote areas may have not 6, but 12, but more, depending on the distance and the time that it takes to make all the program that is visiting all households, controlling the pregnancies, controlling vaccines cards, etc. So, but it was in Brazil, community health workers are, if you go to the Ministry of Health today, probably there will be a manifestation in front of the Ministry of Health of community health workers wanting a threshold of the salaries, etc. So it's a quite complicated issue. There is probably in terms of caucus in health in the national parliament, it's the second more important.
I think we would all love to spend the rest of the day continuing this conversation, but unfortunately we need to move on in our agenda. So please join me in thanking Professor Campos.